I'm at the 14th Congress of the European Association for Clinical Pharmacology and Therapeutics, which is meeting in Stockholm. I'm here with one of the keynote speakers, Dr. Markus Zeitlinger.
I'm working at the Medical University of Vienna and I'm head of the Department of Clinical Pharmacology.
And what was the key theme of your lecture at the meeting?
It was optimization of dosing of antimicrobial agents by means of PK and PD.
And that raises the obvious question, why is it so important to do this? What's the background reason to be so careful?
Well, the idea was that a couple of decades ago, politicians and healthcare professionals claimed that the battle against infectious disease is over. Well, it's not. Actually, the first people are dying again because we do not have any antimicrobial agents that are active against the pathogens. So we have two possibilities actually. One is we have to enhance the development of novel agents, and the other one is to make better use of those that we have already in hand.
And what are some of the main reasons why antibiotic resistance is becoming such a problem?
Well, probably because of the widespread use and of the misuse of antibiotics. Many of the practitioners use antibiotics without thinking. They give it for wrong indications, for treating viral infection, for example, and of course also into production of food. Antibiotics are widely used actually as a growth enhancer of the animals. And therefore we have seen unknown resistance rates throughout the world. I think one of the main reasons is that broad-spectrum antibiotics actually became available also in countries that have not a long history of using very potent antibiotics. Nowadays, when we look at the world, the highest rate of resistance is not in the Western world, interestingly enough, it's in the less developed world, it's in Africa, it's in former Eastern Europe, and it's also in Southern Europe.
And coming on to the detail of your particular interest, would you say a bit more about why it's so important and what you can do by checking levels to be more careful about getting less resistance?
Some of the means that we can use are really very easy. For example, we have learned in the last decades that by prolonging the infusion duration of beta-lactam antibiotics, we can dramatically enhance their activity. So, for example, in intensive care setting, there is a Lancet Infectious Disease publication, for example, you can increase the activity of those antibiotics dramatically and the number needed to treat, so to say, simply by introducing this prolonged infusion is about 10, which is in contrast to the number needed to treat for a statin to prevent cardiovascular disease for 40 to 400.
And in which sort of patients is it very important to do the monitoring?
It's always important in those patients at highest need, so for example intensive care septic patients.
So in your hospital, how does it work in practice in terms of the service you're able to provide?
Yeah, we provide therapeutic drug monitoring for approximately 20 different antimicrobial agents. And of course, simply measuring those levels is not sufficient. Of course, you need consulting then by clinical pharmacologists or by infectious disease specialists of the physicians, because otherwise you simply have a trough level, but you don't know what to do with this.
And we've been hearing elsewhere at the meeting about precision medicine, about differences in metabolism of drugs between patients. Mm-hmm. So do you see surprising needs for much lower doses or much higher doses than you'd expect from older-fashioned ways to assess patients?
Sometimes, because the interplay is very complex. You have factors like obese patients, you have of course the age of the patients, you have the renal function, you have the hepatic function, then you have polymorphism, then you have sepsis as such, then you have the administration of catecholamines, and all these together actually results in a nearly unpredictable pattern of drug exposure, so we need therapeutic drug monitoring at the end of the day.
So you're illustrating what you can do at a high level teaching hospital in a major city. Mm-hmm. We're here at an international meeting, and there's two levels to what's obvious to follow up. One is how well disseminated is this practice in Austria, and what about the contrast between the developed countries and less developed in terms of what is practical for cost and making this available more widely?
Yeah, this is a very good question. I think even in Austria it's not developed enough, but when you think about less developed country, there won't be the possibility of therapeutic drug monitoring in each and every patient. So what you can do is you can use antibiotics that have a relatively narrow pattern of activity, but a broad therapeutic range. With this, you are relatively safe, and a lot of beta-lactam antibiotics actually fulfill this niche.
I suppose one other aspect in less developed countries is concern about supply chain and perhaps substandard, lower activity medicines at best, or contaminated medicines in the chain. So that there's a strong need to be sure you're using the right quality agent, and yet more difficult to be able to do that.
Yes, fortunately most antibiotics are pretty stable, so theoretically you could ship them throughout the world, but of course the supply chain is an issue, especially when you talk about costs.
Thank you very much indeed.